tomorrow afternoon or so. So you can look forward to the slides and presentation tomorrow afternoon. Please use the questions feature to ask any questions that you have, and the chat feature box just for any other chat that you'd like to have during the webinar. We are Shared Action HD. We're funded by the Centers for Disease Control and Prevention to provide free trainings and one-on-one technical assistance for health departments and CBOs on evidence-based interventions and public health strategies, monitoring and evaluation, organizational infrastructure and program sustainability, and alignment with NHAS and HIP and HIV and AIDS services. We'd like to acknowledge AIDS Project Los Angeles, the Centers for HIV Identification, Prevention, and Treatment Services at UCLA, and the Centers for Disease Control and Prevention for making this webinar possible. Our presenter today is Rob Lester, and Rob has been working in the field for around 6 years and started as a volunteer at a CBO in Dallas, Texas. He received his master's in public policy at UCLA in 2012 and has been serving as a health policy consultant since then. And without further ado, I'd like to introduce you to Rob Lester.
Thank you, Patrick, for the introduction, and thank you all for joining us here today. The Affordable Care Act promises a variety of changes for the way in which healthcare is delivered in the United States, and given how important the healthcare system is to those living with HIV, I think it's really important that we all understand how the ACA will affect healthcare and what steps we can take to ensure that we are well positioned to take advantage of all that it can offer, as well as to meet the challenges that its implementation will likely bring. So in the presentation today, I want to hit on a few topics. First, I'm going to start with a brief overview of the legal system and the ways in which that influences the implementation of the Affordable Care Act. Then we'll move on to the ACA itself. We'll hit on how coverage is expanded, the individual mandate, what it means and what it is, who's left out and coverage gaps, how the ACA will affect Ryan White, other important provisions of the ACA that affect the delivery of care to people who are HIV positive, some recommended next steps that providers can take to position themselves for the implementation, and as Patrick mentioned, we'll leave some time, a fair amount of time at the end to take questions. So in terms of the overview of the legal system, I realize this is for some people this will be some pretty basic information, but I think it's important to understand the path from the passage of a law to the delivery of the services to how this affects the delivery of services to clients, and how this path is influenced by the decisions that people make along the way. Now, the passage of a bill is only the first of many steps to building a new federal program. Statutes usually delegate broad authority to executive agencies to write rules and regulations. And these rules define the terms of law and control how it is implemented. Now, the rulemaking process is governed by the Administrative Procedures Act, which is a federal law that dates back to the 1940s, I think. And in theory, it's fairly straightforward. An administrative agency issues a draft of a law, they take comments, and they take those comments and come and produce a final rule or regulation. Then sometimes they'll follow up with some guidance that gives a little more information on how they'd like to see it implemented. This whole process can occur again at the state level with statutes, regulations, and guidance. And ideally, this results in clear language that explains what the statute means from the perspective of the administrative agency and how it is to be implemented on both the federal and state levels. In reality, it's a tremendously messy process, with many of the participants working at cross purposes. Deadlines of the statutes that are included in the statute may not be followed because it just takes too long to develop a rule that makes all the necessary stakeholders happy, or at least that all the necessary stakeholders are willing to assent to. States may just straight up refuse to cooperate. We've certainly seen that. And finally, the judiciary can become involved in the process at both the state and the federal level, and that can obviously make any existing plans about the sort of timeline really stretch out tremendously. Just as an example, after the passage of the Affordable Care Act, several states got together and sued, saying the law was unconstitutional. Obviously, that case wasn't successful, but state officials thought the law might be. State officials also thought that the law might be repealed if Romney won the election. They didn't want to begin working on developing laws or rules to implement it because they didn't want to be seen as endorsing healthcare reform, especially when those officials were from conservative states that didn't support it. For a lot of them, the way of thinking was sort of like, why go out on a limb and write regulations to implement the ACA and risk political backlash if the law was going to be overturned or repealed? So what should have been a 3.5-year-long process of developing a clear set of rules to implement the provisions of the Affordable Care Act kept getting put off and kept getting put off, and now we're in a situation where we have basically 11 months to write rules and regulations to implement a tremendously complex law. So kind of what all this means is that there is unfortunately still tremendous uncertainty about what the experiences will be, how the law will be implemented on the ground, and how our clients will experience that when the law is finally implemented. So moving on to coverage options. Now the purpose of the ACA, at least in theory, the purpose of the ACA is to increase the number of Americans covered by health insurance and to decrease the cost of health care. In the discussion today, we're really going to focus on how it expands coverage and leave the ways in which it does or does not decrease the cost of health care in the long term for another day. So under the Affordable Care Act, there will be 4 types of health coverage available to individuals. There will be group or employer-based coverage, which is what most people in America currently have. There will be individual coverage, Medicaid, and Medicare. So let's go through those kind of one by one. So for employer-based coverage, the ACA contains tax incentives to encourage small businesses to offer coverage. They receive subsidies. And by small businesses, I mean those with 1 to 25 employees. For larger employees, that is those with 50 or more employees, there's some tax penalties that can be imposed in certain situations if they don't offer coverage. The ways in which the Affordable Care Act interacts with employer-based coverage are pretty complex, but I think we can pretty much sum it up at this point to say that most coverage should stay about the same in the short term, though it is likely that some employers will drop coverage and some premiums will increase. In terms of the individual plans, now individuals will be able to purchase coverage for themselves or their families in state-based marketplaces. These marketplaces used to be called exchanges, but at some point the administration decided that they should be called marketplaces. If you hear me refer to a state-based insurance exchange, that is the same as a state-based marketplace, and I have just not caught up with the regulatory terms at this point. So if the marketplaces work envisioned, then individuals will be able to purchase health insurance online, by phone, or through a broker by providing a few basic pieces of information: their age, their income, the number of members of the family that will be covered, their location, and whether or not they use tobacco. Now, even in the best case, many will still need guidance choosing among the various options. So people will need help determining how to weigh premiums versus deductibles and copays, how expansive the formulary is and whether or not that suits their particular needs, and how expansive the network is. Those whose income is between 133% of the federal poverty level and 400% of the federal poverty level, and this is about $15,000 to $45,000 for a single adult, they'll receive subsidies that are paid directly to the insurance company. The premiums and out-of-pocket expenses are limited to a certain percent of the income, which depends, and that limit depends on the income as well, but it still may be relatively expensive for some people. For people who do not have chronic health conditions, the coverage will probably be pretty good. It'll be somewhat expensive, especially people with lower incomes, but they'll have catastrophic coverage in place and they'll receive free preventive services. For individuals who have chronic conditions, especially something like HIV, where there's a lot of medication involved, many people still experience some pretty significant challenges in terms of paying for medication on a month-to-month basis, depending upon the exact terms of the insurance plan they buy. So this is, I think, this is the place where it's really important that Ryan White providers can step in and help individuals understand what the implications are for the various insurance plans. So moving on to Medicaid. Now, individuals with income, as a broad rule under the Affordable Care Act, given there is tremendous variation among the states, generally individuals with income less than 138% of the federal poverty level will be eligible for Medicaid. Now, the original text of the ACA eliminated all Medicaid funding for states that did not implement the expansion, but this was overturned by the Supreme Court. And thus, some states have chosen not to implement the Medicaid expansion. I'll come back to kind of what this means and go over that in a little more detail, but just understand that Medicaid will be a major provider for people moving forward, and that unlike in the past where the ability to access Medicaid services was contingent upon falling into a particular status category like being a child under 18 or being a parent of a child, in the future will be solely based on income, at least for those states that choose to implement it. Finally, Medicare. This is obviously the federal insurance program for people 65 or older. Most provisions of Medicare will remain the same from the perspective of enrollees. However, the donut hole will be closed by 2020, and from 2014 to 2019 will be reduced. For those of you not familiar with Medicare, the donut hole is a gap in coverage in which individuals are required to pay 100% of the cost of their prescriptions when the cost is above $2,700 but less than about $6,100. So obviously for people who are on Medicare and who are HIV positive, the narrowing or eventual closure of the donut hole will be a tremendous advantage for them. So just to kind of provide an overview of all this information. Like I said, I am skimming over a lot of details here, and I will we'll be sending out a report that follows up on this that will go over this in more detail. But I think the most important points about this are that most employer coverage will probably stay the same, but there's going to be a lot of exceptions to that moving forward. If you don't have employer coverage, you can purchase coverage through an exchange or a marketplace, and that your premium may be subsidized depending on your income. If your income is very low, below about $15,000 for a single adult, you'll be eligible for Medicaid unless your state doesn't opt into the expansion. And finally, Medicare will continue to pay pretty much as it is, will continue to be pretty much as it is, except that the donut hole will close by 2020. So the individual mandate. Now, this is one of the most contentious parts of the Affordable Care Act, obviously. I think anybody who has a television knows how vigorous the discussion was about it. One way to think about the individual mandate is if you consider auto insurance. Now, everybody who owns a car, or almost everyone who owns a car, I think there's one state that doesn't require this, is required to have auto insurance. The reason we have this was some of the people have auto accidents that require large payouts. And these payouts can be much larger than an individual's ability to pay out of pocket. Now, obviously, you can't purchase auto insurance after you have a wreck. You can't call up Progressive or Geico and be like, man, I just had a wreck. Can you cover that? But they would be like, no, you've already had the wreck. If you think of health insurance as is sort of similar, insurance companies are required to issue coverage without excluding pre-existing conditions, and they can't charge more for health reasons. So why won't people wait until after they're sick to purchase coverage? And the reason why is because of the individual mandate. So the individual mandate plays a role in stabilizing the health insurance market and ensuring that even though we require the insurance companies to issue coverage to people regardless of the health condition, that people do their part and buy the coverage before they get sick. So that's the purpose of the individual mandate. So what is the individual mandate? The mandate requires all non-exempt individuals to obtain minimum essential coverage or to pay a penalty. So there's a lot in that statement, so let's unpack it a little bit. Non-exempt. Basically, this means everyone who is a citizen, a national, or a legally resident alien that isn't otherwise exempted. People who might otherwise be exempted from the mandate include people who file for religious exemptions, so people who have a religious objection to health insurance in general, members of certain ministers and other religious officials are exempted, members of Native American tribes, people whose family income is below the threshold requiring them to file a tax income. I believe in 2010 this was about $9,300 for an individual and maybe about $18,000 for a family. So people who are very poor are not required to obtain coverage, but they will still be eligible. Just like people with the religious exemption, they're eligible but not required. And if you have to pay more than 8% of your income for health insurance after taking into account any employer contributions or tax credits, again, you are exempted, but you're not prohibited. You don't have to. Finally, individuals who are not lawfully present and individuals who are incarcerated are prohibited from purchasing health insurance from the exchange. And when I say individuals who are not lawfully present, that's kind of statutory speak for undocumented immigrants. Individuals who are incarcerated, that's people who have been to trial, been found guilty, or have pled guilty and are in a state prison. Finally, individuals who would be eligible for Medicaid but live in a state that is not opting into the Medicaid expansion will not be penalized for not obtaining coverage. So minimum essential coverage. That's a government. Generally, that means a government health insurance program such as Medicaid, Medicare, or TRICARE, which is the VA, or which is the system for members of the armed services, a qualifying employer plan, or a qualifying individual plan. By qualifying plan, most plans that will be publicly available will qualify probably. People might be able to go search out some plan that was very limited coverage or that only paid maybe a very predefined benefit that wouldn't qualify. But generally, if you receive coverage through your employer, through a large employer especially, or if you receive coverage through an individual through a state-based marketplace, then that would be considered qualifying or minimum essential coverage. Finally, the penalty. In 2014, the penalty starts off pretty low. I think it's $95 per adult, or with $47.50 per child, up to $285 for a family, or 1% of family income, whichever is greater.
Is that a penalty per year?
Yes. Okay. And then it goes up in 2015 to an amount that I don't have written down. And then in 2016 and beyond, it's up to $695 per adult, and about $350 per child, up to $2,000 or $2,085 per family, or 2.5% of family income, whichever is greater. So the idea with that structure is to give people a few years before they really start imposing harsh penalties. And those penalties, the way that's structured, it's added onto a tax bill, but the IRS cannot file a lien against someone's assets for it. I don't really want to get too deep into that, but just know that it starts off fairly low. It works up, but there's a couple provisions in it to make it, people won't be going to prison or they won't be charged for not paying their taxes because they don't pay the tax penalty. But they will certainly get it taken off their tax refund if they're eligible. So who will be left out? Currently in the U.S., about 84.3% of people have some sort of health insurance. Now, under the best case scenario with the Affordable Care Act, that is if all states choose to opt into the Medicaid expansion, we think coverage will probably go up to 93, 94%, although that model makes a lot of assumptions, so that's probably really just our best guess. Given the number of states who have chosen not to implement the Medicaid expansion, my back-of-the-envelope calculation suggests that a more realistic expectation moving forward would be that about 90% of Americans will have coverage. Obviously, the people who do not have coverage aren't evenly distributed among all income groups, so as is so often the case, people who are less well-off economically will be disproportionately burdened with a lack of coverage. So who will the aside from people who are, so who will be specifically left out of that? Well, those people who are exempted that I mentioned before, although many of them may choose to participate. People who are the very poorest people in society who who don't sign up for Medicaid. What I mean here generally is people who, maybe homeless people, individuals with some sort of medical or psychological illness that prevent them from being able to efficiently access the services that are available. Obviously, there is tremendous opportunity for CBOs to play a role in getting these people into care and getting them signed up to the programs for which they're eligible. But that will be an area where the way it's structured, it requires citizens or people to participate to make some affirmative action to obtain coverage. So for those people who don't really have the resources available to do that, that can be a problem. There will be some people who are stubborn and simply don't want to do it and would rather pay the penalty than do it, obviously. Individuals who are not legally present, that is, again, undocumented migrants, they're prohibited from participating in Medicaid, and they're also prohibited from purchasing health insurance through the state marketplaces. So the undocumented will be a major component of those people who are uninsured moving forward. And finally, individuals in states without the Medicaid expansion. So the Medicaid expansion, we've mentioned this a few times. Next slide. So we have a fairly decent idea of which states will participate and which states won't, although as the map there indicates, there's still, I think, 5 states that won't, or haven't made a decision, maybe 6, it looks like. Of those who, if the Affordable Care Act were fully implemented, then we think the Medicaid expansion will cover 10.3 million people. Again, my back-of-the-envelope calculation suggests there's about 3.6 million of those people that are in states that have said they will not implement the Medicaid expansion. So how will those people receive care? Well, if they are currently eligible for other benefits, including Ryan White, then that would be one potential source of care. Actually, let me back up. How will those people receive care? How will they receive insurance? The short answer is they won't. They'll be in the same situation they're in now. So if they currently receive benefits through Ryan White, they will continue to do so. The Affordable Care Act directs a fairly considerable amount of funding towards health centers, which include federally FQHCs and FQHC lookalikes. So these people might have an opportunity to obtain care there. They might be eligible for Medicaid through some other provision. So if they're under 18, if they're the parent of a child that's eligible for Medicaid, if they're 65 and on low income, if they're disabled. Again, this varies a lot from state to state because states have so much latitude in implementing Medicaid. But basically, if your state chooses not to implement Medicaid, you'll be in the same boat in the future that you're in right now. One final thing to note. The original Medicaid Act was passed in 1965. It took 17 years for all the states to choose to opt in. So I think the expectation right now is that even though there's a fair number of states that aren't choosing to participate, that over time more and more states will opt in. But we don't really know how long that'll take for everybody to get on board. Finally, how will the Affordable Care Act impact Ryan White? There is significant uncertainty moving forward. Our best guesses really are that current funding will continue for the next 2 or 3 years, but that depends upon Congress deciding to allocate additional funds after September of this year when funding runs out. Obviously, there's a tremendously strong public health argument for continuing to fund Ryan White, but it's really difficult to predict how Congress is going to vote given how contentious the current budgetary politics are. Medium and long term, as more people transition to coverage, wraparound services will become more important. Ryan White covers many services that are not included as essential health benefits, which the new insurance plans are required to cover, and some that are not covered by health centers, which is one of the other sources of care in the future. So these additional services that Ryan White offers will probably be a major rationale for continuing the program in the future. But as I said before, potentially more care will be delivered to clients through health centers. As currently uninsured clients transition to Medicaid, which some providers may not choose to accept that, so that'll direct more people towards the health centers. And finally, because there is no provision within the Affordable Care Act to provide health insurance to people who are undocumented, Ryan White will continue to be an important source of coverage for people who are undocumented going forward, although there is, of course, some uncertainty about how that will play out politically. Finally, other provisions of the Affordable Care Act that will affect the delivery of care for people who are HIV positive. Healthcare reform will almost certainly increase the demand for healthcare providers. The Bureau of Labor Statistics projects that between 2010 and 2020, demand for physicians will increase by 24%, for physicians' assistants by 30%, and for RNs by 26%. The medical labor market has high barriers to entry, such as education and licensing requirements. Generally, in a labor market with high barriers to entry, when there's a steep increase in demand for services, you have either wages increase or there are shortages or both. There are several provisions within the Affordable Care Act to prevent this from happening. Unfortunately, because of the dynamic nature of labor markets, we really don't know how effective these provisions will be. I think the best case scenario, and this is really just sort of my back of the envelope guess, actually it's just a guess, is that we'll have a couple years that will be difficult and then things will smooth out. We don't obviously know that's what's going to happen. If the provisions are not as effective as we hope they are, if other issues come up that we haven't fully anticipated, then it is possible that we could see an extended period of time in which individuals who have recently obtained coverage have difficulty accessing care. Let's see. So other issues, there's increased funding for healthcare centers. I mentioned this briefly. The original Affordable Care Act directed, I think, $11 billion in funding for health centers. Congress, the year after, cut that by $600 million, so it leaves $10.4 billion on the table, which is still a considerable increase in funding for health centers. When Massachusetts expanded their health insurance coverage or began to require health insurance coverage, they noticed that many people who obtained Medicaid had difficulty accessing care. We anticipate that the health centers, with their new funding, may be a good source of care for people who have recently obtained coverage and can't access it through private practice physicians. Finally, accountable care organizations. Basically, an accountable care organization is when providers band together and agree to accept a lump sum payment for seeing a set number of patients. This may positively affect the treatment of people who are HIV positive by basing compensation on treatment outcomes, and it may encourage the development of treatment modes that place greater value on cooperation among providers and actively encourage the patient to participate in care. For patients who have particularly complex medical conditions like HIV that require, or cancer, or a whole list of other issues that require numerous different providers from different specialties to work together, this type of incentive structure may be very advantageous. Ideally, problem patients, that is those who are disinclined to actively participate in their treatment, will receive additional supportive services, and the Affordable Care organizations will work to bring those people into treatment and to get them involved in their care. That is certainly our hope. Uncertainty moving forward. So there are some questions that we certainly do not have the answers to. We don't really know how the Medicaid expansion is going to play out. We have a pretty good idea of which states are going to participate, but we don't, for those that don't participate, we don't know if and when they will choose to do so. There is uncertainty over funding for Ryan White after the current funding allocation expires in September of this year. We don't know. We don't really know if healthcare providers, if there will be a shortage of healthcare providers, and if there is a shortage, how severe it will be or how long-term it will be. And finally, we don't know how smooth the intake process is going to be. The Affordable Care Act contains numerous provisions explaining how the federal government would like for the marketplaces to work. HHS is busy writing and issuing regulations about how they want to see it work. Many states play a large role in this, and some states will be very competent and very efficient. Some states will not be. So the experiences that clients have in one state may be very different from the experiences that clients have in the others. And with 50 states, some will be implemented well and some will not, and some people will have good experience and some will have poor, so that is something to bear in mind. Finally, there's another area of uncertainty. What I've just mentioned are several questions that we don't know the answers to, but at least we really know the questions. In implementing a program this complex, there will be some questions that we haven't even anticipated. So I think it's important to keep an eye on unexpected outcomes and interactions. We can't necessarily make plans for these, but we can be alert for future problems so that we can get ahead of them before they develop. I think for most people this really just means taking some time, perhaps as a staff once or twice a month, to look at outcomes and identify potential issues and ask ourselves, is there anything that we thought would work in a certain way but it's not? And are there any problems we haven't anticipated that we can see developing? And finally, even though we still have a lot of questions and there's some considerable uncertainty, I think even though there is considerable uncertainty, we still have the ability to plan ahead and to anticipate this and to stay in front of these so that we don't wind up getting overwhelmed by it. So next steps. There's a lot of information that I've kind of thrown out in this presentation, and as I've mentioned repeatedly, a lot of uncertainty. There's also high diversity among providers. So unfortunately, I can't really tell you what will happen to your clients, but there are some questions you can ask that will help anticipate the specific challenges the organization will probably face. So this includes some really basic things like, is my state participating in the Medicaid expansion? And how are we choosing to implement the insurance exchange? Is it being run by the state? Is it a state-federal partnership? Is it being run by the feds? And to the degree, and if it is being run by the state, well, no matter who is running it, how is it going to look? How is that going to impact, or how is that going to affect our clients? Your clients. what situations are they experiencing most frequently? If you live in an area, or if most of your clients, many of your clients are undocumented immigrants, then you have a very different set of challenges moving forward than if most of your clients are documented or are U.S. citizens. If most of your clients make under, make under the federal poverty level, and you live in a state that's not implementing Medicaid, then that suggests a very different set of concerns than for people whose clients are mostly relatively higher income and live in a state that'll probably implement a fairly comprehensive insurance exchange. So all this is getting at what sort of assistance are your clients going to need? And by asking this, you can get in front of the you can get in front of the changes that are coming down, and be ready to give and have some questions or have some answers ready for your clients when they come in and when they have issues. And finally, your agency itself. What services? Ask yourself, what services do you currently offer? How will these meet the needs that our clients will have in the future? And what new services can we offer that will help them meet their needs in the future? And of these new services, what should you offer yourself? And are there any that you'd be better off referring to other organizations? So, in conclusion, there we go. So many of the organizations, many of you who are online work for organizations that have been offering services since the early days of the epidemic. And you guys have built effective, competent programs in response to the needs of your clients. However, healthcare reform will likely mean that many of the programmatic needs will change. New organizations and new forms of health insurance and coverage will be available for those who are HIV positive. Despite this, I think it's important to remember that your organization still has experiences, strengths, and advantages that your clients will value. And the challenge moving forward is to figure out what your clients' needs are and what role your organization can play in ensuring that those needs are best met.
Okay. And with that said, we'll move on to the questions and answers portion. I guess the way we'll handle this today is, if you'd like to ask a question that hasn't already been asked in the questions box, you can go ahead and raise your hand through the GoToWebinar interface, and we will unmute you, and you can go ahead and ask your question to Rob directly. So we already have a question that asks, when you talk about staffing needs and you refer to RNs, were you referring to NPs?
The Bureau of Labor Statistics does not. I assume in the question you're referring to the potential increase in demand for healthcare providers between 2010 and 2020. I tossed out a figure saying I think the anticipated increase is 24%. The Bureau of Labor Statistics does not break down nurse practitioners separate from RNs. Given the increase in demand that we anticipate for physicians and the difficulty of getting new physicians trained and into practice, I anticipate that the increased demand for nurse practitioners will probably look more like the increased demand for physician's assistants, although that will vary considerably from state to state, depending upon the scope of practice laws within a state. The more permissive the scope of practice laws are in a state, the more the demand should be, and the more restricted, the more limited the demand should be.
Okay. And again, if you wish to ask a question to Rob directly, go ahead and raise your hand, and we will unmute you so you can speak over the conference. So another question that we got previously is, what can Medicaid exactly be billed for?
So beginning in 2014, all non-grandfathered health insurance plans will have to cover essential health benefits. What I mean by grandfathered is that certain plans that were in existence at the time of the passage of the Affordable Care Act are exempt from many of the new regulations. Those that are not grandfathered in are required to offer a set of essential health benefits. Now, HHS has issued the regulation defining essential health benefits. Unfortunately, or well, not unfortunately, the regulation varies from state to state. So what the essential health benefits are depends on what state you are located in, because the reference that they use to define this is the most common, is based on, varies from state to state. So what the minimum essential health requirements are that you can build a private insurance plan for or Medicaid for will depend upon what state you're in. That's probably the best we can do with that one.
A question we just got is, does the ACA also cover dental?
I don't believe so. I can certainly check.
From what I've seen, I haven't seen any mention of covering dental. It's just primary health care.
Yeah. I would imagine that unless the dental situation rises to a primary health care concern, it's kind of a fuzzy line between the two. So health, like semi-annual cleanings, no. Filling cavities, probably not. Severe periodontal disease that requires more extensive interventions, that might be covered. Mm-hmm. This is one of those things that we haven't really seen much guidance on yet.
Okay. If someone has a Social Security number and lives in Mexico or any other country, what happens then if they need medical services in those countries?
I do not know. That is an excellent question, one I can follow up on.
So we'll add that. We'll go ahead and add that question to the briefing document that we'll send out to everyone that's attended this webinar, probably sometime next week. So you can look forward to the answer then. Another question we got is, Ryan White is the payer of last resort. What happens to clients who are required by the individual mandate to apply for insurance but simply fail to take action?
Again, I haven't seen any regulatory guidance that explains what would happen in that situation. Clearly, I mean, there's two things that can happen. One, the person remains eligible for Ryan White and continues to have their medications covered through it, or because it is payer of last resort, they're going to say you have some other option, and we're not going to cover it. I think this would be a place where CBOs have a real opportunity to work with their clients to ensure that they receive that and that it doesn't become an issue. I don't know what will happen if it comes down to the wire and a client straight up refuses to obtain coverage.
Okay. And I intend to just clarify that EHB includes pediatric dental coverage. And we also got more coverage questions about the ACA, about vision care and behavioral health.
Yes, behavioral health, mental health, and substance abuse is a category under essential health benefits. However, again, how comprehensive those essential health benefits are will vary from state to state. I don't believe that vision care is covered, though.
And again, I haven't seen anything on vision care, just like dental. So we can look into that more and provide a more clear answer in the briefing document.
Okay. Next. No. Let's see.
And another question we just got is, will home health care be covered under ACA?
I imagine that'll depend on what particular type of coverage you have. I believe Medicare currently has some provisions for home health care. Medicaid is much less expansive with their coverage. I don't think home health care is covered as an essential health benefit, although again the definition will vary from state to state.
And we received some questions previously about the Indian Health Improvement Act and how the ACA will affect it. If you have any clarification about that.
Sure. So one of the provisions of the ACA made the Indian Health Improvement Act, or permanently established the Indian Health Improvement Act, and expanded the range of services that can be offered under its authority. Coverage expansions include mental and behavioral health treatment and prevention, long-term care services, dialysis services, facilitation of care for Indian veterans, and urban Indian health programs. It also included greater funds for increasing clinician recruitment and retention in tribally operated health centers. And finally, some provisions that increase IHS reimbursement through third-party billers such as Medicare, Medicaid, or private health insurance plans.
Okay. Is there a deadline where people have to sign up for ACA coverage, or is it just going to be kind of an ongoing enrollment throughout the year?
The penalty will apply to people who have a greater than 3-month gap in coverage. Some of the information I've seen thus far suggests that some plans will have specific enrollment windows. So kind of like if, for those of you who have, for many of you with employer health-based insurance or with employer health insurance, you have a particular window, maybe 30 or 60 days towards the end of the year in which you can sign up. You're not allowed to alter your coverage other than that. Other plans may have open enrollment. There's pretty broad latitude within the Act itself and within the regulations for how a particular individual plan wants to structure enrollment. And they are allowed to have up to a 90-day a 90-day exclusion after you sign up for care. There's a term for that that escapes me right away.
And another coverage question, though vision may not be covered, will ophthalmology be covered?
Again, essential health benefits do not require, to the best of my knowledge, essential health benefits do not require vision coverage. However, the regulations implementing the essential health benefits provision of the Affordable Care Act are written such that HHS will define those essential health benefits separately for each state. If you live in a state in which it is customary for coverage to include ophthalmology, then it is likely that your plans will include ophthalmology moving forward. However, if you live in a state in which that is not customary, it is much less likely that moving forward that will be considered an essential health benefit within your state.
Okay, and the questions keep on coming. Great. So, where were we? Will Ryan White programs eventually be dismantled once ACA is fully implemented? That's a good question.
That is an excellent question. I've spoken to a lot of people about this, and I think the feedback I'm getting suggests that long term, so 10, 15 years down the road, what looks most likely is that Ryan White will offer the sort of wraparound services that are not covered under essential health benefits. So things like legal assistance, housing, maybe some specific food aid, these sorts of programs that are part of Ryan White that are not part of your traditional health insurance plan, but that play a large role that play a large public health role in ensuring that people who are HIV positive receive effective, competent care. In the short to medium term, given how many states have chosen not to implement the Medicaid expansion, I expect that Ryan White will continue to play a role in ensuring that HIV positive people within those states receive medication and receive care. The more states that choose not to opt into the Medicaid expansion, the greater the incentive for retaining Ryan White in its current form. And as more states opt into the Medicaid expansion, there is less of a public health rationale for preserving parts of Ryan White that directly provide care like ADAP. There's a number of variables in trying to figure out what will happen going forward, and I don't think anybody really has a good sense for how those will work together.
So the short answer is stay tuned, and we'll see as everything rolls out.
Yes, that is correct.
Will the plan cover medical supplies or home medical equipment?
Again, excellent question, and
we'll look into it and we'll include it in the briefing document.
Yeah, I think these are excellent. The coverage questions are excellent, and some of them I can certainly look up and get back to you guys on. But again, there's a tremendous amount of variation. Even with the regulations that have already been written, there is still tremendous variation from state to state that we just don't really know what's going to happen yet. And there will almost certainly be lawsuits over it, so that will play a role in it.
Great. What happens if you were on COBRA? How do you transition and keep having your continuous coverage?
If you are currently, let's say it's in 2014 or afterwards, and you are receiving employer-based health coverage, and you lose your job, or you leave that job for some reason. Part of the reason that COBRA was included in the original and was originally created was to allow people to have a coverage as they transition from one job to the next. I haven't seen anything, when I read over the bill, I didn't see anything specifically eliminating COBRA. So that may still be an option, or I assume that will still be an option moving forward. For somebody who exhausts COBRA, they will have the possibility, they will have the option of buying an individual plan through a state-based marketplace. But the idea that the need to have continuous coverage is built around the idea that pre-existing conditions are excluded so long as you have that continuous coverage. The Affordable Care Act prohibits insurance companies from discriminating or from adjusting coverage based on pre-existing conditions. So once you take that piece out of it, the ability of insurance companies to say, oh, you have a pre-existing condition, we won't cover it, the need to obtain continuous coverage as envisioned under COBRA really goes away. And then it becomes a matter of, do I choose not to have insurance for more than 3 months, and how is that going to affect my tax bill, and do I want to kind of take that sort of risk in, maybe having an accident or whatever, rather than how do I ensure that I have this continuous coverage so that I don't get kicked into a waiting period when I get my next job.
Right. So say I'm someone who's uninsured and this an ACA finally goes into effect. How do I know what plan is kind of appropriate for me? Are there guidelines in line with target key age, demographics, income, physical address?
Are there guidelines issued by the federal government? No, there are not. I think this is a place where CBOs and Ryan White providers have a real opportunity to make a place for themselves. Some of our clients who have been ill since the earlier days of the epidemic have tremendous depth of knowledge about what their particular medical needs are and how insurance works. Those people will obviously be well placed to make these decisions for themselves. Other clients who have less experience dealing with the intricacies of private health insurance or who are less well adapted to advocating for themselves will have considerable difficulty in navigating the system. CBOs will be well suited to help people walk through that. Because of the diversity of plans that will be available and the diversity of experience of life situations that people have, it's difficult to make sort of blanket recommendations. But I think that CBO staff that is reasonably competent in what the terms of an insurance policy mean can assist clients in navigating that particular aspect of it themselves.
So how will the ACA impact employer-paid group insurance plans? Will employers have to kind of force their employees to purchase their own insurance?
The way in which employer-based coverage is treated under the ACA depends upon the size of the employer. For small employers, that is those with 25 or less employees, the company will receive a tax subsidy if they choose to offer group health insurance for their employees. I believe they can also use that. I'm not sure how the subsidy, people who work for small employers will also be able to purchase coverage in the individual market. For medium-sized employers, those 25 to 50 employees, there's neither a tax penalty for not offering it nor a tax subsidy for offering it. I think that what will happen there is that most people will probably purchase coverage through the individual market. For those employers with 50 or more employees, if those employers have employees that choose to purchase insurance through the individual market and that receive a subsidy for that purchase, then they're penalized in paying their taxes under certain conditions. In terms of analysis, I think most people expect that we'll see probably a 5 to 7% decline in the number of people who are covered by employer health coverage, and probably an increase in premiums in most or many cases. Beyond that, it's really difficult to project how this will play out because there's a number of factors that come into play that we don't really know. so much of the way in which employer-based in coverage is, so much of what we experience in that is based on compensation norms, and as those change, then when compensation norms change, it becomes difficult. It's hard to model social norms, and as those change, it becomes really difficult to project like how the economic situation is going to play out.
Right. Will medications be tiered the same way it kind of is right now with Medicare?
Most Medicare will probably continue as it is, except for the exceptions that I mentioned earlier with the donut hole, and there'll be some more preventative care included. What formulary tiers a particular plan chooses to implement will be up to that plan, I believe. I'm sure there's some restrictions. HHS requires qualifying plans to offer at least one medication within each class of drugs, with the class of drugs defined by reference to the U.S. Pharmacopoeia. But beyond that, plans have pretty broad latitude in deciding how they want to structure deductibles.
For people on Medicare right now, will they expect any major changes in terms of accessing medical care?
Preventative services will be covered fully, I believe, under implementation of the ACA, and the donut hole will change. In terms of accessing care, that depends upon the larger healthcare market. The ACA included some reductions in provider reimbursements for Medicare treatment, but there's other provisions that are already in place in Medicare that incentivize providers to provide coverage or provide care to people who are on Medicare. So short answer is we don't really know. I think given how important Medicare is for most providers, it'll probably stay about the same. I think they'll take that issue with the reduced coverage, I think they'll take that up with their congressmen and senators rather than letting it affect care for people.
Right. So we're going to go through our last two questions, and we're going to wrap up. It's 11:55 here on the West Coast, so I want to make sure we get you guys out on time. So for most people, so for the income under 400%, won't coverage purchased through an exchange likely be more affordable than through COBRA?
Yes. There are some incentives built in the Affordable Care Act to try to push large employers towards keeping the cost of coverage down. But it is entirely possible that it will be cheaper for an individual to purchase care through, or to purchase coverage rather, through the individual market. How that affects large group coverage in the long term or medium term is an area that there's been a lot of ink spilt about, and I don't think anybody really has a good clue for that. But from the individual's perspective, yeah, it may be entirely more reasonable to purchase it through the individual market than to retain cover.
So are there network providers associated with each plan? So if I purchase an ACA plan, what are the guidelines there for choosing a provider that will accept the coverage that I've purchased? I think this ties in also just to the general availability of providers, because as soon as ACA is enacted on, there's going to be the floodgates are going to open, and a lot of these primary care providers are going to be receiving a lot of new patients.
Yes, we anticipate there will be an increase in demand for healthcare providers. Which providers are associated with a particular plan, it's up to that plan to negotiate. I mean, these are still private health insurance plans. So just like if you get a new job and your health insurance plan changes, you'll have potentially a new set of providers. It won't be any different. What providers are available for a plan depends on what that plan was able to negotiate with the providers. For people who are on Medicaid, people who are on Medicaid traditionally have experienced greater challenges in accessing providers. We expect that challenge will increase, and that may be an area in which healthcare centers, or FQHCs rather, play a large role moving forward.
Great, and there's one more question I want to touch on because I think this is a really good question that we haven't addressed yet. So when considering Ryan-wide grant management issues, should CBOs start setting up contracts with insurance companies to provide HIV counseling and testing, since that will be a covered service under the ACA?
That is a great question, and to be honest, I'm really hesitant to tell people, yes, you need to do X, Y, or Z with regards to your organization because there's so much diversity. If insurance carriers in your area or in your state are going to cover that, and whether or not they will cover that depends upon, again, essential health benefits in your state, and it's also made in reference to the U.S. Preventive Services Task Force, which has it's sort of a complex issue that I don't really want to get into right now. Yes, that is definitely, short answer is yes, that is definitely something you should consider. You should look at the terms of the contract and decide whether or not that works for your organization. That's sort of the short answer.
All right. Well, I'd like to thank Rob here for joining us today and presenting on the ACA, and thank all of you again for your patience in dealing with last week's technical issues. I'm glad that we were able to give this webinar to you guys, and you should look forward to the next couple of weeks because we'll be continuing kind of the same topic, where next week on Thursday at 11 a.m. Pacific time, we'll be having the second part to our strategic restructuring webinar, and that does address the ACA in a couple of ways. So if you have more questions about the ACA, feel free to send them to us, and we'll go ahead and get those out to you in a document sometime next week.
Thank you guys for, I will be following up with a more extensive report covering all of this in detail, and I will definitely include some of the coverage questions that you guys had. I think they're great questions. And again, it was a pleasure to discuss the ACA with you guys.
And I just want to make everyone aware that we have educational materials on our website on the ACA and on other topics at sharedaction.org. And as well, for one more announcement, in 2 weeks, on Thursday at 11 a.m., we'll be having a survey design workshop. So if you work with surveys in any capacity in your organization, this workshop is designed to just give you as much information as possible to help you design great surveys. And we've tried to design it to be as short as possible, but also give you practice in designing the surveys. So you'll not only be able to get the information about them, but following that webinar, that workshop, you'll be able to participate in smaller work groups and work through a survey with other participants, as well as a facilitator. So you can look forward to that, and you'll be receiving an email about that workshop shortly. Please give us feedback as soon as this webinar ends, and as well in the follow-up email from GoToWebinar, you'll receive a post-webinar survey. Please fill it out. We have some questions that we want to be able to use to give you guys the best service possible through these webinars and workshops. And again, I'm Patrick Stanley with Shared Action and Shared Action HD. If you would need to email me or call me if you have any questions about the ACA, or if you have any questions about any other CBO services that we provide, please feel free to call or email me. And you can go to our websites, sharedaction.org and sharedactionhd.org for further information. Thank you very much for attending, and have a great day.